Hello, everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Preemie Chat series is one of many initiatives we have to bring information for NICU families and healthcare professionals. And today and next Friday, we are doing a year in review of COVID-19. Today's session is a collaboration with the International and National Family Integrated Care Committees and is sponsored by AbbVie. Well, it's been 1 year. Nobody imagined that COVID-19 pandemic would be the center of our lives for such a long time. And the light at the end of the tunnel is still too dim to let us see when all this is going to end. The numbers are still staggering. The pandemic has changed every aspect of our lives, the way we work, the way we shop, how we entertain ourselves, the way we connect with our friends and families. It heavily affected the economy, the healthcare system, our children's education, everyone's mental health. For the families of preterm babies, it has been an extra layer of stress. Since the beginning of the pandemic, restrictions were put in place in NICUs around the world. Parents, unfortunately, became visitors. The stories that are coming to CPBF and other organizations around the world are heartbreaking. And research has shown the short-term impact, and we can only predict the long-term impact on babies' development and parental mental health. And this is what we are going to address today with our three guests, Dr. Carol O'Brien, Dr. Marsha Campbell-Yeo, and a parent who experienced 2 NICUs during the pandemic, Daniela Taylor. And I will start here today with Dr. Carol O'Brien. Let me bring her to the stream. Hi, Dr. O'Brien. And she's going to talk about parents as essential caregivers in the NICU. She'll present on why parent engagement in the care of their infant in the NICU is important for both the infant and the family, and how parental presence needs to be supported even during the COVID-19 pandemic. She's going to talk about the findings and recommendations of a paper she has been working on. Dr. Carol O'Brien is a staff neonatologist at Mount Sinai Hospital and associate professor of pediatrics at the University of Toronto. She's a clinical teacher and neonatologist. She has trained in clinical epidemiology and healthcare research. Her current research has focused on the development of family integrated care, a model that changes how we deliver care to families and their infants in the NICU. And she has recently completed the international trial of this model of care. Going forward, Dr. O'Brien is passionate about the importance of including families in the care of their infants and investigating how best to support the entire team, nurses, physicians, and parents to provide this care in a way that improves the staff, family, and infant outcomes. Her motto is, be the change you wish to see. Dr. O'Brien, thank you so much for joining us here today. I'm very excited for this conversation. Oh, we cannot hear you. Let me unmute you. There you go.
I was just saying it's a pleasure to be here and really to be the first speaker of this COVID week. I know that I recorded my talk earlier this week because I was concerned that I wouldn't have good internet access, but here I am live for now.
Yeah, so we are going to play our chat, and then we are
here to answer questions live.
Exactly, and you can send your questions, your comments on the chat box below, and we're going to address in just 15 minutes. Let's do this. It's hard to believe it's been 1 year since COVID started, and you're still having this conversation about parental presence in the NICU.
No, thank you, Fabiana. It's my great pleasure to be the first speaker in this year in review event. I can't believe it's been a year. This has been a very difficult year for the families of preterm infants. Who would have believed that this pretty virus, which looks almost like a Christmas decoration, would cause such disruption in the world? The Canadian Premature Baby Foundation has done an amazing job. Really, you need to be congratulated for supporting families by the dissemination of knowledge about family integrated care and partnering with our FICARE National and International Steering Committee to support the implementation of family integrated care in Canada and worldwide, and supporting families throughout this pandemic. I think Canadian Premature Baby Foundation have done a wonderful job. But today I'm here to talk to you about the impact, what we know about the impact of COVID-19 on family-centered care. And here are the objectives of my talk. Really, at the end of this talk, I want people to understand why parents are important to take care of their babies in the NICU. I also want you to understand what the impact of COVID-19 has been on NICU policies and how parents have been affected, and also to understand how parental presence in the NICU can be supported, even through the pandemic. Yes, it has been a horrible year, with many celebrations and get-togethers postponed, but one thing I have learned as a neonatologist is that families of preterm infants and the infants themselves are amazingly resilient. So no matter what the families have been through, no matter what the babies have been through, I think there's hope that people will recover and go on normally after this, despite what I'm telling you today. So why is family engagement in care so important? Well, preterm infants have an increased risk of subtle changes with learning, communication, movement, and behavior. And the causes of behavioral problems are multifactorial, including the effect of parent-infant interactions. Behavioral problems impact the day-to-day function of the family and can have an impact on school success. Now, several research reports, not just from Canada, but from around the world, have shown that parents can play a really large role in providing direct care of infants in the NICU, and that there are short and long-term benefits from this practice, including improved infant weight gain, decreased nosocomial infection or infection that's acquired in the NICU, decreased parent stress and anxiety, decreased hospital length of stay, reduction in readmission to hospital, and improved breastfeeding. The image at the bottom of this slide illustrates how much the baby's brain develops in the last weeks of pregnancy. If you look from 35 to 40 weeks, there's a dramatic growth of the brain during that time. Parent-infant interaction is key to shape the development of the brain. Attuned parents providing developmentally responsive care furthers the normal brain development. Also, in addition, parents in the NICU suffer themselves. They suffer because of the stress and separation from their baby and often from each other. The trauma of the NICU care. We know that there are many traumas that parents are exposed to in the NICU. And parents in the NICU have an increased risk of depression and anxiety. The parent's emotional state, both in the NICU and beyond discharge, impacts their ability to respond to their infant and therefore impacts the long-term health of themselves and also their family. So family integrated care is a whole package that supports parental presence, and it includes both, as you see here in this slide, parent-delivered interventions and parent support interventions. So it encompasses both of those things. But to execute it requires commitment to a culture change in the NICU. It demands shaking up the system of care and looking at everything we do through the lens of the family. This is a quote from Fabiana. What we want to achieve is that every family can be their child's best medicine, just as Fabiana was. So how did we go from this picture, parents being essential caregivers in the NICU, to this, locked down NICUs? We went back to our own old way of doing things. Instead of embracing families in the decision-making about how best to protect their infant and the staff, we responded out of fear. Infection control became the primary objective during the first wave of COVID last spring. The sharing of information with families was haphazard and policy varied from hospital to hospital. The report above from Mahoney et al. Was a cross-sectional survey of 27 NICUs in the US, and some of the responses illustrated the severity of the lockdown. As you can see, 7 sites, 3% actually completely prohibited parents. Our collaborators on our International FICARE Steering Committee, here you see on a Zoom call, came together to review what has been published about the impact of FICARE on families and developed a statement on parental presence in the NICU during COVID. That statement has been posted on the Family Integrated Care website and also through the Canadian Premature Baby Foundation, and we're hoping it will be published shortly. What our review of the published literature has shown is that uniformly there have been changes in NICU policies across the world since the beginning of this COVID pandemic. So almost all hospitals have some form of entry screening. Most hospitals revoked 24-hour access to the NICU. Many hospitals said just one parent at a time could visit, even though the parents were both living in the same household, and that makes absolutely no sense. In most hospitals, there was decreased access to food and rest space for parents, and also there were decreased lactation and therapy supports for both the parents and the infant. Interesting, we could not find reports of in-hospital transmission between neonatal patients or their parents. When routinely screened, and there was the NICUs in Italy that actually routinely screened both staff and parents in the NICU, that the incidence, the rate of positivity in the NICU was the same as in the community. Transmission in hospital generally occurred between staff, breakout rooms, and mask-off areas. Mothers of infants in the NICU reported not receiving enough information on expressing breast milk or receiving breastfeeding support. Mothers frequently reported not being able to provide skin-to-skin care to their infant, and that they were not encouraged to hold as soon as possible after birth and had problems with bonding with their infant and engaging in care. There have been increasingly identified concerns for parental mental health, with increased risk, particularly of anxiety and post-traumatic stress disorder. The inconsistent treatment of parents across sites is worse than ever, and with each hospital having its own policy. Parents are generally not able to remove their masks at all, and that will likely impact speech and language development, at least in the short term for the infants. In addition, there are reported impacts on healthcare professionals who have been traumatized by witnessing parents' distress, the lack of PPE in their areas, and their fear of contagious parents or possible contagious parents. So it's been a really rough time. This is a slide that I've borrowed from Fabiana. So these are quotes that were provided through the Canadian Premature Baby Foundation. And I know that Marsha will be presenting the results of her family survey in addition to this. It is our first child and we felt robbed of the experience. I think that feeling of being traumatized by the experience, being terrified at the bedside, having flashbacks 9 months later, the rules changing so much and the poor communication of rules. My family still doesn't understand what I went through as I stayed alone with my baby in the NICU. And again, there's a comment here about I still feel very much alone as everything became virtual. Virtual does not replace the in-person connection, as we all know from our Zoom meetings with families. So what are we going to do about this? Well, we're working with the Canadian Premature Baby Foundation and the European Foundation for the Care of Newborn Infants and our international and national committees, and have developed a position statement that we have submitted for publication along with this review of the literature. The guiding principle of this position statement is that parents are not visitors. They are care providers, just as they're dedicated care providers in long-term care homes. And therefore, they should be treated in the same way as other care providers are. I'm going to read out to you the highlights of the statement to provide some more information. Both parents should be with their infant on the neonatal unit and postnatal ward unless they are symptomatic or have been advised to or required to self-isolate or quarantine. There's no rationale for just one parent to be with their baby. Parents should be involved in their infant's care without time restrictions. Again, there's no rationale for time restrictions. Parents should be provided with the same protection as staff. That is, they should be provided with medical grade face masks. and provided on arrival to the hospital or the NICU, depending on the environment. Parents and staff should know how to adhere to physical distancing policies in the neonatal unit or postnatal ward. All parents and staff should be educated and apply appropriate hand and respiratory hygiene measures within the hospital and the home environment. So parents need to know how to keep themselves safe, to keep their babies safe, and to keep their nurses safe. Where possible, dedicated space should be available for parents to safely eat and rest on the neonatal unit or nearby so as to be close to their infant. I think there are going to be lots of stories from Marsha's talk about how parents have suffered as not being able to remove their mask at the bedside. Appropriate technological support, including video calling and apps, should not be used to replace parental presence in the unit, but can be used to support parental involvement and communication. And neonatal teams should make every effort possible to provide additional measures to support parental presence, including the provision of face masks, accommodation, parking, and transport. And we did actually make a comment about masks, and we say that where a safe physical distance can be maintained between staff and families, parents should be supported to take care of the infant at the cot side without wearing a face mask or with a clear face covering if available. And there are clear masks which have now been approved by the FDA for use. We've also made a comment about vaccines. As vaccines become more available, parents as primary caregivers and members of the neonatal team, fully recognized active members of our team, should be given early access to vaccination in NICUs to reduce the risk of transmission between staff and parents, and vice versa. It's a two-way street. Luckily, spring is coming. This was a quote that said, when you're at the end of your rope, tie a knot and hold on. We're going to get through this pandemic together, and things will get better. What we have really learned from this, though, is that when we're practicing family integrated care or family-centered care or whatever we want to call family integration, we need to integrate families into the decision-making, even if it's an emergency. We cannot afford to go back to our old way of doing things. As we will continue to promote parental presence in the NICU and parental engagement in medical decision-making at the level of administration at the hospitals. In the second wave, most hospitals have been much more careful about what they've been doing with parents, and we will make sure that this continues going forward. Thank you, Fabiana, for all that you do to keep us pointed in the correct direction. Thank you.
Thank you, Dr. Brian. I hope you can, okay, there you are. Thank you so much for presenting all that information and for the amazing work that the Site Care Committee is doing to really put this position paper together and to bring this information out. So there's so many questions that we needed to address, and so much into the unknown, and so many NICUs around the world is still with a lot of restrictions for families. I think my first question to you is that we've been debating that a lot. Is family-centered care in jeopardy with all those restrictions?
You know, I don't think family-centered care is in jeopardy. I know you are fearful about that, Fabiana. I think our response last March was out of fear. I think infection control just said the safest thing to do was lock the hospital doors. If ideally they would have liked to have kept the staff in and everybody else out. You know, but that's not tenable long term. And I do believe that things will get back to better. I think this has been a wake-up call to all of us, though, about how fragile our systems are, and things that we think are established can change at a moment's notice. So I think it is a call for all of us who support family engagement and decision-making at the hospital level to make sure that we have more robust systems in place to maintain that going forward, and to highlight to hospital administrations that what errors were made this time around and how we can not make those in the future. So I think it's a call to arms. I do not think that we've lost the thread, though. I do believe that family-centered care and family-integrated care will be back on every hospital's agenda coming this fall.
Well, we'll certainly keep advocating for that. And I think one of the pillars of FICARE is to really bring the peer support to the veteran parents inside the hospital and have these parent partners inside the units. And we had made unbelievable strides over the last few years having that kind of engagement. And we're really, for a lack of better word, upset as parent partners is that once the pandemic started, and as you mentioned, all that fear-based decisions were made, the parent partners were not consulted or didn't provide any advice. Do you see this happening in the near future, where the parent partners are again consulted and sit at the tables with the policymakers and to discuss protocols in hospitals?
Yeah, I definitely do see this coming forward. I think one of the leaders in this area has actually been the long-term care facilities. And I think in some ways we need to latch on to that. They've been very vociferous about family members being care providers in long-term care and making sure that family members are engaged in that kind of decision-making at the unit level or at the long-term care facility level. I think this will be examined closely in the coming months, and I hope that we can bring forward the discussion about NICU care, ICU care, and hospital care as well into that, and make sure that family members are regarded as decision makers in those environments as well.
Absolutely. So we have a question coming here from our live audience. Does FICARE look at maternal care standards at all? Is the need for additional support to out-of-town families considered?
So FICARE for sure. FICARE is focused on the NICU today, but the idea of additional support and provision of accommodation and transport and food, those are all things that we've highlighted as part of the pillar, the environmental support for family integrated care. I think it's really important, whether it be in the regular postnatal ward or whether it be in the NICU or PEDS ICU, the acknowledgement of the need for family support to support prolonged parental presence. Parents need to be there. So therefore, one of the pillars is this environmental support.
Absolutely.
Thank you.
We have a question here from Daniela. Actually, Daniela is the parent who is going to be speaking right after Dr. Marsha Campbell-Yeo, and she's going to be sharing her experience in 2 different NICUs. But her question is, what can we do as parents for those of us affected by these issues to minimize the negative effects of this? Will there be any support for us?
So Danielle, if you're asking about minimizing the effect for you long-term as a person, I think one of the things is I know that there are additional psychosocial supports being provided for families, both through the Canadian Premature Baby Foundation and through the Perinatal Mental Health Network at Mount Sinai. So that's somewhere for you to go to get resources. From a bigger systems point of view, I think this is one of the areas that we need to look at longer term in our follow-up clinics to see what sort of support families need, particularly around speech and language and socialization of the children going forward. I think that's a really important question. Thank you for highlighting it.
Yes, absolutely. And yes, if you're watching us, the COVID care program is something that CPBF started earlier in the pandemic to provide 2 therapy sessions free for families with clinicians from across the country. So the application is on our website. I'm going to share the website here with you. And it's a COVID care program. The form is there is a self-referral, and we have psychologists and perinatal mental health specialists across the country, depends which province the family is. So it's obviously it's not the solution of the problem, but it's something that we are trying to help families with to reduce a little bit of the stress. And peer support is very important. We have a lot of, we have groups, real-time peer support groups on our Facebook, and all the information is on our website. And I was actually, this week I learned that BC Women's hired a psychologist as a part of staff, which is something very unique in Canada, and I'm very happy to learn about that initiative. So I think the hospitals are looking to support parents from the mental health point of view, because we know the stress here is much bigger than was ever before. I think we have one more comment here from Shannon. Losing our family mentors at the units was devastating. We are engaging them as much as possible and doing Zoom calls via Zoom. I'm thrilled that we've been able to keep this happening as much as possible. Shannon, can you just remind me which hospital you are? I think you're in Edmonton, if I'm not wrong. And this, we know there's been a lot of hospitals that the parent partners were not working anymore or not allowed to come back into the units, but other hospitals are still doing, and I know Sinai is been doing a lot of online work. Dr. Carol Bryant, talk to us about what is Sinai doing online for families.
So as I mentioned in my talk, we know that online is no substitute for in-person. However, online at this time has been a real lifesaver for some families. So first of all, our parent education is being done through online. That is, the parent education has a dual purpose, I would say. It builds a community with peers of other parents who are in hospital at the time that you're in hospital with your baby. So it allows for that peer-to-peer connection. It also allows us to introduce veteran parents into those education sessions who actually provide some what we call veteran parent supports, graduates of baby soup and in the NICU, or parents of graduates. So we have these online education sessions. We also have an online ability to attend rounds virtually. And so that's something that was introduced. It was introduced before COVID, actually, to facilitate, because we realized that there were some families who could not attend rounds in person, and we didn't want them to feel that they were missing out on something. So that's why we introduced these virtual rounds. During COVID, that became a lifesaver for families, and oftentimes, particularly when one parent was present and the other parent couldn't be here. So we've used rounds in that context as well. And thirdly, with the help of funds from Pampers and the Canadian Premature Baby Foundation, we've been now able to introduce the app called VCreate to our unit. I think we're the first Canadian site to be able to do that. And that is where we can actually record small video messages, not real time. And we would send them to the family, particularly in the evenings or when they're not in to see their baby. So we're using technology in many different ways in the unit right now. We know it's no substitute for parental presence, particularly parents hands-on and holding skin to skin and just being with their baby. However, it's something to actually support the connection and help parents not feel so isolated or so traumatized by these events.
Absolutely. We have a comment here from Daniela. Actually, year-round sessions were a lifesaver for us, and we've been hearing this from many other families. And we also interviewed a doctor in, I think, October from also Edmonton, who's been using technology from the delivery room so the parents can stay connected with the baby until they are able to go to the NICU. So there's a lot of different initiatives and ways to use technology, but as you mentioned, this is not to substitute, to replace the family presence in the NICU. Dr. Bray, I want to chat with you about the screening process, because I know you've been advocating since the beginning for parents to be screened just like healthcare professionals. So how is this happening now? Because I know you talk to a lot of other hospitals across the world. So how is this going?
So basically, families are being screened in the same way as healthcare professionals at the door on the entrance to the hospital. They're now recognized as care providers with an ID that identifies them separately to the screeners at the door.
Okay, I think we lost
going in for an appointment or whatever. Can you hear me now?
Yes, now you can. You were frozen for a few seconds.
No problem. So I was just saying how families are recognized by a badge, and they're identified to the screeners at the door as being different than patients who are coming in for a clinic appointment or coming in to see their doctor. And so they're actually asked to go through the same screening questions as staff and to self-screen and provide that information to the screeners as they arrive. They're also provided with medical grade masks on arrival to the hospital so that they can, in the same environment. The hardest piece that we've had most difficulty with at our hospital, I would say, is the whole question about where can families eat safely. and how we can support their prolonged presence at the hospital. And that's something that's is still in the process of changing. We created a safe area for eating for family caregivers, where they can actually take off their mask to eat in the hospital, but it's not ideal. But that's probably been the biggest challenge. As I mentioned earlier, I think it's the mask off areas in the hospital where most transmission has occurred. And I think that's why infection control have been so scared of creating mask off areas for families to eat in. It's dependent on the families having the knowledge and having the same goals of care as the medical care providers, as in to keep everybody safe, both themselves, other parents in the unit, and their baby. So I think that's what.
Yeah, we heard from a lot of families they've been eating in their cars. So we know the stress is all around, but we also know this is also an issue for staff in many units where they also don't have a safe place to eat or to rest during the day.
Correct. I mean, this is something that I hope that will be, we haven't really got a good solution to yet, I would say, in any of the hospitals that I've spoken to. And certainly the publications have not yet come out saying how we're going to support this. So this is something that infection control and us are going to all have to work at in the future. You know, we had provided lounges for staff and lounges for parents, but no division, no separation for people from each other. And no way really of monitoring those areas, either staff areas or parent areas. So I think that's where infection control just got really nervous about what was going on in those spaces.
Absolutely. So I have a comment here from Laurie Romas. Trying to buy groceries in a strange city with no vehicle of support was so hard. I lost so much weight not eating. So I know Laurie was out of town for almost 2 months. She was transferred from Kenora to Winnipeg, and she couldn't cross the border because she was actually in the beginning of the pandemic transferred the very first week, and the borders between Ontario and Manitoba was closed. So I know Laurie shared her story with us before, and it was a very hard time for her. So I have another comment here from Marianne. Next important steps coming out of the pandemic, steps to moving back to fully site care, ensuring that technology is only jumped. Absolutely, Marianne, we agree. And which hospital you're referring to, Dr. Brian? Is Mount Sinai Hospital in Toronto?
Correct. That's where I work, is at Mount Sinai Hospital in Toronto.
So we have yes. Go ahead.
No, I was just publications internationally. So not just Mount Sinai. It was actually on the international publications that we did a formal literature search to try and find out what's been published about the hospital policies and restrictions.
Okay, we have a question from Nikki. I work at McMaster Children's Hospitals and ICU and helped to establish a peer support group prior to COVID-19, but found when the transition to online, we had minimal turnout. Any advice? And Nikki had a very strong group at McMaster. They've been running the snack and chat for many years there with a lot of participation. So any advice, Dr. Brian?
That's really good, Nikki. I know it took a while to get family integrated care started at McMaster, so you're to be praised for that. I think one of the things we found actually, Nikki, for some reason, I'm not sure whether it's because we've had a tradition of parent education sessions, but we've actually found the transition to online parent education sessions with peer-to-peer support has been really good. And we've had great attendance with the online sessions. I think one of the things that's been key is trying to get the information to families. So having a routine time for those presentations that cannot change from day to day, so families know when to log in. I think that's really important. I think the other thing is making the sessions so they're not too formal. So there is a combination of peer-to-peer support and some information being provided. That really helps. So having whether the hook to get families in is either peer-to-peer support or education and information. I think that's really important. For each type of person, it can be both or either. So I think having a combination of both was found to be really effective.
Okay, so we have a comment here from Brooke. Love the idea of supporting families using Zoom calls for bedside rounds. It is something that I hope many other areas of hospitals can look into that, because it's not only for NICUs, any part of the hospital could be very, it benefited from it, really.
I think the logistics oftentimes scared people initially, because you have to book an appointment with a family, and it requires that sort of planning ahead. What time are you likely to be doing rounds at a certain bed space with, see, your baby? So I think flexibility on both sides was really important. You know, rounds might be running a little late, or we may miss you today, something happens. So I think that sort of flexibility was key to making success, but it's been very effective.
Absolutely.
So I'm glad to hear that.
So we have another comment from Shannon. She's at Stollery in Edmonton. I'm the peer support coordinator, and I've been able to visit families in person, as well as have volunteer family mentors who I take in bedside on iPads to visit with parents. That's great to hear, Shannon. Thank you for sharing that with us.
I think, Shannon, one of the issues that's been really different, though, across the country, and I think you have to take this into account, is that the peaks and troughs of COVID have been different in different places. So depending on the instance of the disease in the community, the anxiety in the hospital changes. So I think it's been very different so I really feel sorry for families in different areas where they've hit the hospital when it's at peak times, and things have just not been so easy for anybody. Even, for example, even physicians were not allowed to enter the hospital unless they were on clinical service in Toronto for a number of months.
Right. So one more comment here. I'm looking for some research to support phone-based peer support. Would you like to develop a phone-based program for our volunteers to be able to contact parents directly? Well, this is a great idea. And Sinai has been doing the Parent Buddy program for many years, but it's
correct.
Right.
And so there is some published research on that as regards phone-based peer-to-peer support. And the Parent Buddy program at Sinai is probably the ultimate program in the country, and has some published research. So I would encourage you to contact the social workers at Sinai. And I know, Fabienne, we can provide the name offline. It's somebody to contact to further that discussion.
Okay, and we have one more suggestion here. It would be nice if there was an engagement app so that parents could connect with nurses and checking on their baby at any time to make engagement easy. They can't be there physically. Any comment on that, Dr. O'Brien?
So no, I think that's a great idea. It depends on what engagement is. And that's one of the things. Engaging with your nurse or engaging with your baby. So the engagement with your baby, I think the vCreate app will probably help facilitate that in some ways. But remember, your nurse's primary job is actually to take care of your baby in hospital. And of course, to take care of the family as well. But all of those require sort of I would say, a scheduling in a nurse's day. So I think it would be really important when we're looking at these things to make sure to sustain a model like this requires looking at it from all parts, to realize, yes, the primary is looking at the parents and the baby, but that's always been the challenge. But I think a great idea. I think we just need to look at how it works for both people.
Absolutely. Dr. Brian, before you wrap up your session, from your recommendations, you also saw there was an impact on the staff, the stress of the staff in the NICU. Can you talk a little bit, how are the NICUs running with the nurses and the whole team in terms of stress level, how they have been affected with this?
I think that has yet to come out. I think that publication, we only found a few publications talking about it, and many of them were talking about, NICU was not seen as a priority area for PPE. That sort of, there was mixed messages as regards the risk of exposure to staff from families, and the fact that because there was that sort of divide between we want families in, and yet staff were afraid of having families. So that created some distress for staff. I would say we have a huge turnover of staff. Many of the staff who are near the age of retirement have retired now over the last year in the NICU. I know many of the nurses across the country have retired. So there's a lot of young staff coming in, which is both good because those are the staff who will embrace technology Not as good perhaps, as they don't have as much knowledge coming in, but are very flexible in their learning. So it works both ways. So I think, and I think really you've also heard that staff have been really traumatized by not being able to support families in the way that they want to. So, I know there have been some stories of families not being able to come in for end of life with their baby, or there have been families who have not been able to, the baby's critically ill and the families have not been present. And I think nurses whose primary job is in caring for the baby and the family have been really upset by not having families in, because their role is generally to support families, not just the baby. And so it's, that information is just coming. I know that that's part of the work that is being led by Marsha, is actually to look at a survey of staff as well as of parents to see how COVID has actually affected the staff.
Absolutely.
Yeah.
So we have one more question here. Is the option of a live cam realistic for Canadian hospitals? There is actually this technology available. The NICU View is a 24-hour streaming. There's no sound, but there is a live streaming with the baby.
So we looked into that before we went with the app, and it was very expensive to install, very expensive to maintain. And the other problem is that it actually created some distress among the staff. When we've had a discussion around, should we allow live streaming all the time? Because one of the things, there are things going on at the bedside, there are things going on in the room, there are other discussions among staff that are really, for privacy concerns, should not be shared with families. Particularly if they're discussing another patient or there's something going on close by the next room. So there were lots of concerns about that. I think in some of the units in the States, yes, it's being used. I think there's only one unit in Canada. I think that may be Saskatoon, I believe, who have the NICU in place. But certainly I think that's an area that's worth continuing to monitor and see what's out there. We just don't have it in place at this time.
Right. There are actually a few more hospitals that we learn about. Danielle, if you're interested, you can join. You can listen to one of our podcasts with Dr. Jennifer Toy from Edmonton. They've been using her unit, and she's sharing her experience and the staff and parents' experience with that technology. But we are up now, and Dr. Brian, thank you for joining us here today. We are going to take a short break, less than 5 minutes, and we'll be back with Dr. Marsha Campbell-Yeo and Daniela Taylor to talk about the survey that was done in Canada and the parent experience. Dr. Brian, thank you so much for joining me here today. Always a pleasure.
Thank you.
And learning from your experience. Thank you. And thank you, everyone who are joining us from Facebook or YouTube channels. I also want to thank the International Family Integrated Care Committees for all the work they are doing and for the collaboration with CPBF on these 2 sessions from today and next week. And also I want to thank AbbVie, who made possible for those 2 sessions to happen this week. And the video of today's session and all the other videos from our live series are available on the CPBF website, which is canadianpreemie.org. I will share the address here with you. And I will take a very short break, and I'll be back in less than 5 minutes. Thank you. Stay with us. Hi, Daniela. On mute. So hello everyone, welcome back. And if you are joining us here now, welcome to this Preemie chat. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization and our mission is to support and educate families of premature babies. This Preemie chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. And today and next Friday, we are doing a year in review of COVID-19. Today's session is a collaboration with the International Family Integrated Care Committee, and it's sponsored by AbbVie. If you missed our first session, I talked to Dr. Carol O'Brien, and the video of her session will stay on our streaming, or on our feed on Facebook and YouTube. In a few days, I'm adding to our website, which is the CanadianPreemies.org. And right now, we're going to talk about the impact of COVID-19, restrictions on family presence and well-being in Canadian ICUs, the results of a parent-targeted national survey. And I'm going to bring her here, my guest now, Dr. Marsha Campbell-Yeo. Where are you on this broadcast? Let me bring you to the live. Let me see what's happening here. Okay, I can bring you to the stream. Give me 1 second. Oh, here you are. Okay, I'm sorry about that. At the technology, 1 year later, I'm still struggling. So Dr. Marsha Campbell-Yeo is a neonatal nurse practitioner and clinician scientist. She's a full professor at the School of Nursing, Faculty of Health at Dalhousie University, and holds cross appointments in the Department of Pediatrics and Psychology and Neuroscience. Her Canada Foundation of Innovation funded research lab, MomLink, is located at the IWK Health Center in Halifax. She primarily holds grants examining maternally-led interventions to improve outcomes of medically at-risk newborns, specifically related to pain, stress, and neurodevelopment, as well as a novel knowledge synthesis and dissemination methods and digital e-health interventions aimed at enhancing parental engagement. And Dr. Campbell-Yeo just joined CPBF as the chair of our inaugural Scientific Advisory Committee. Dr. Campbell-Yeo, thank you so much for joining us here today. It's so nice to have you here. And I finally got the technology to work, so I have you live.
Thank you, Fabiana. I'm absolutely thrilled to be here. And I see we have a very, we didn't organize this, but we have the same wardrobe. I think great minds think alike.
Absolutely. Okay, so I know you have a presentation to share with us, and I will let you share your screen. And we are going to have a Q&A period at the end. And please send your questions and your comments on in the box below, and you're going to go through them after her presentation. Go ahead and you can share your screen.
Okay, let's see if my technology works on my end. Okay, here we go.
Okay, give me 1 second, because it is the problem is my screen when I click to try to share, because we have too many people in our green room. Patricia, if you're there, can you leave the green room so I can add to the stream? Here you go. Okay, we got this working.
Okay, so am I sharing?
I don't, yeah, now I see your slides. Maybe you just put on a presenter, like on a slide view, and there you go.
Are we good? Can you see me and hear me, Fabiana? Fabiana, can you see and hear me? I can't hear you, Fabiana. Can you see and hear me?
Hi,
Hi.
Marsha. We can hear and see you. So if you want to share your screen, you can go ahead. We can hear and see you.
You can? Okay,
Yes,
because
it's working. Just share your screen again and we go ahead.
okay.
Here you go. You can make a full slide and then you're good to go.
Okay. Can you see that there?
Yes.
Okay. All right. It just doesn't want to see. Here we go. We're all good now?
All good now.
Excellent. Love. And just think, I work in technology, but thank you so much, Fabiana, for your kind introduction and having me here today to share the preliminary results of our National Parent Survey regarding the impact of parental presence restrictions on Canadian families in the NICU during COVID-19. So I have nothing to disclose. As many of you have heard from Carol's talk and others, it's no surprise that over the past decade, we've spent tremendous amount of emphasis on trying to find optimal ways to increase parental presence, engagement, and integration in the NICU. We know that this has really been in response to strong evidence regarding the infant benefits related to greater parental presence with respect to greater brain development, decreased stress response, reduced length of stay, and improved growth. We also know that in addition to the infant, it benefits that parents benefit greatly from parental presence with greater well-being, with reduced stress, anxiety, and depression. But of no surprise, given the talk that we just had from Carol, that really with the onset of COVID-19, it seemed like this entire paradigm shift really was entirely eradicated, with parents, or certainly significantly compromised, with parents being reassigned very quickly from the partner in care philosophy to having visitor status. And so we knew that across the country, both in our center and at many centers across Canada, that various units were putting in place different types of parental presence restriction policies. But we really didn't know what the variation was across the countries, was with the NICUs, nor on the impact from a largely versus just certain sites, but really from a Canadian perspective. So what we did was, as part of a smaller study that we were conducting in Nova Scotia, funded by the Nova Scotia COVID Coalition, our team launched a national parent survey. And also in collaboration with Fabiana at the Canadian Premature Baby Foundation, as well as with some input from Dr. Carol O'Brien and the FICARE team. And the aims of our survey was really to try to understand from a Canadian parent perspective the impact of parental presence restrictions in response to COVID-19, gain an understanding of the potential variation in practice and policies across the country, and to identify potential gaps and opportunities to improve care for infants and families. And so the survey really consisted of 8 primary sections. We collected information regarding parent demographics and their babies. We wanted to know about specific information about the policies themselves and mobility in the hospital. We wanted to understand about technology use, as well as certainly the stress and impact of families that they experienced. We asked questions regarding COVID exposure, and we also embedded 8 questions that we could collect qualitative narrative that was optional for parents to complete. So the survey was put on a RedCap. It's a secure server in which you're able to just easily click on a link to respond. It was launched in November 2020, and it will stay open until next Friday, March 12th. We recruited via social media, NICU forums, online classified ads, email to stakeholders and posters in the units. And for any of you who potentially have not provided any feedback, if you are a family of a baby who was admitted in any Canadian neonatal intensive care unit after March 1st or were there on March 1st, 2020 and going forward, you can easily just go to our research lab, www.mumlink.ca, and there will be a pop-up and you can just click on and complete the survey if you're interested. So what did we find in our preliminary results? Well, to date, we had 233 respondents. We were very happy to see that those respondents were representative across all of the Canadian provinces, as well as Nunavut. And if you look across the bottom axis, that talks about the percent of which provinces the respondents were from. And of course, the provinces on the vertical axis. We can see that the majority of respondents were from Ontario with 35%, followed by Alberta and Quebec, and then with other slightly smaller numbers from the other provinces. So with respect to the respondents, the infants of the respondents, there were about 65% of them were little boy babies. They were primarily singletons, over 90%. About a third of the respondents had infants who were actually term infants, with about a third of infants being late preterms between 32 and 36 weeks, and the remaining third about less than 28 weeks. Average length of stay for people were about 34 days, and most of the families completed the survey after they were discharged from hospital, about 86%. When we asked how close or far you lived from the hospital, parents were, some were very close, others lived as many as 5 hours away, with about the majority, over 2/3, being about 30 kilometers from the hospital in which their baby was admitted. When looking a little bit closer at the respondents themselves, while we targeted that we wanted to have both health moms and dads, we actually had primarily moms respond to the survey, with about only 4.7% of dads responding. The average age was about 31 years. Most described themselves as having white ethnicity, with about 3/4 having some post high school education. The majority, 86%, spoke English predominantly in the home, with the remaining speaking French or other languages. The majority, all but 8%, reported that they were in some form of relationship, either married or common law. And while about 11% of the respondents said that they lived with a household income of less than 11%, the majority reported having between about 50 and 100, about the majority was 100 and 200,000 a year for annual household income before taxes. So to help us understand the responses, we're going to report it not only in total responses, but also within 2 cohorts that we found. So if you think about yellow, in the yellow, about a third of the respondents actually said that they were always able to have at least 2 support people in the hospital at any given time. And about 2/3, in which we talk about higher restrictions, either were only able to have 1 support person or none, actually, in about almost 6% of the cases. So when we look a little closer at that, then when we add on our map, we can see that there seems to be in the low in yellow and the teal, which is reported in high, considerable variation, not only across provinces, but within provinces. And this could be reflective of some hospitals, some provinces having multiple hospitals, all potentially with different policies, as well as could reflect some of the timing in which people actually responded to the survey within their province. So we wanted to know from families sort of what what actually happened related to the parent presence policies. And we can see from the results here, again, reminding that the low in yellow and the high in teal, that about 60 to 70% of the families, regardless of level of restriction, were sent home at night. And that in about 40% of the low and about 30% of the high, that other members were allowed to be with their infant during the NICU stay. We also saw that while about more than 90% of people were expected to have some form of screening for COVID prior to entrance to the NICU, very few actually had to have COVID testing. And we can also see that even with the very high restrictive groups in which only one member was able to be there, we did see that there was switching of family members allowed. So we also wanted to know about how the restrictions actually impacted, again, the person's movement or parents' movement once they were actually in the hospital. So we can see that the majority were provided a mask and sanitizer across the hospitals, and the majority actually could move fairly freely to leave, going outside, either to potentially smoke or have exercise if they felt overwhelmed. And really about 30% actually had of the high restrictive zones could not leave the baby's bedside, and almost 20% in the low. So we're also very interested to ask families about what was the restrictions' impact on their own personal and physical needs. And so we can see that there was actually fairly similar responses, regardless of whether they were high or low restriction policies, on that about 30% of families actually had a very hard time finding or getting access to toilets or shower facilities. Interestingly, most had a place to sleep somewhere in the hospital. About 80% of families and 30%, between 70 and 80% of families were not able to eat at the bedside. And I think quite alarmingly, what we see is that about 55% of our families actually responded that they were hungry. And we heard that from some of Carol's work and some when we talk about some of the qualitative narratives, that this is such a overwhelming number of families to think that they were actually hungry, and that about 20% of families provided free food at some point to the families, and about less than 10% provided food at reduced rates. We also asked about cultural and dietary concerns, and about 20% of families, especially those in high risk, reported significant difficulties in accessing culturally sensitive or dietary needs with respect to foods. So this is a bit of a busy slide, and I'll just take a moment to explain how we asked these questions and our responses. So we wanted to know about how families felt when they were in the hospital with their baby, around sort of the clarity of the policies and how that made them feel. So the questions that we asked are along the left or vertical axis about how the clarity, as we said, how the policies made them feel, and about how they might have restricted their access to their own personal needs for medicine or healthcare. Parents were able to respond in a Likert scale. So we see from the bottom, they could either say 1 of completely disagree, all the way up to 7 to agree. What we see is all these dots and scatter plots is really, this is the raw data in which the respondents, so the bigger the blob, the more the respondents, and then the little blocks that we see, that the main center block talks about the mean responses, with the upper being about the 25th percentile and the lower 75th percentile. So I think if you think about where the boxes land, you can sort of also see about the mean scores. So we can see that while there was similarities across the low versus high, that really the
people in the high restrictions, again, more than 2/3 of our respondents felt that they felt that there was some concerns with respect to how clear the policies were to them. They were more apt to feel undervalued and less respected. And they also expressed more difficulty in receiving access to medications for themselves or healthcare for themselves. So using a similar way to describe the data, we also wanted to know about what was the impact associated with some of the common events that almost every family has happened to them, receiving bad news, medical rounds, receiving medical information, or having their baby admitted. And we specifically wanted to understand the stress or the trauma, and we see the situations for each of the questions on the left, and it was, how traumatic was it to be away from your infant? How traumatic was it to be alone? And how much did they wish that they had a desire to have a support person with them? And again, we can see that it's quite unanimous across all of those questions and situations in which most families agreed or completely agreed that it was quite traumatic. Again, to be away from their infant, to be alone, and their wish to have a support person. The only difference would be is with the level of trauma regarding medical rounds, in which we see that the low group did say that they were somewhat distressed or found it somewhat traumatic to be alone, but not quite as high as some of the other groups. And this could be because they actually didn't have, they were able to have a second person with them. So we also asked similar questions around uncommon events, but with similar contexts around the trauma of being away from their infant, being alone, or wishing they had a support person. We asked about when if an infant died. Thankfully, that didn't happen very often in our cohort, but there were certainly some. Whether the infant had a major procedure, providing consent for that procedure, or when their infant's condition worsened. And again, we can see pretty unanimously that most of the means fall into the agree or completely agree with respect to high level of trauma and wish for having a support person with them. So we also wanted to know and try to understand how much did the parent policies actually have for add additional stress? So I think all of you who've had a baby in the NICU, and for us who work, we understand that it's extremely a stressful time for families. So we asked the question, taking that into account of how stressful it is being in the NICU, how much more stress do you think these this parent restriction policies had on you and your family? And we asked families to rate from no additional stress on a scale of 0 up to 10, worst possible. And we can see that for the most part, there was very little differences between the cohorts, with about 60% saying that it was very distressing to worst possible additional stress beyond the NICU experience, with about 30% saying it was very uncomfortable or somewhat too distressing above the NICU admission, and about 10%, 9% saying no additional stress or mild. And really the only differences we saw between the low and high cohorts was, for the most part, the high, not surprisingly, were much more likely to say worst possible. And when we talk about no additional distress, it was really only those few in the low restrictive cohort that responded in this way. So we also was very interested in asking about how information was shared and the use of technology across all of the hospitals. And when we asked about communication with the medical team, about 60% received information from use of telephone. Very few received any other type of communication from the medical team with any other type of digital or electronic means. And sadly, about 20% of families actually said they had no communication from their medical team. When we asked families how they stayed close to their infant or their family at home, again, most families use the telephone, about 40%. More, a few, about 15% use video calls, some use text messaging, and again, about 25% didn't use any type of use of sort of digital or technology to help with communication or information sharing. For those who did use technology, the majority used their own device. And for the most part, about 80% in the low and about 60% in the high said that the internet was acceptable or better in the institution and hospital they were at. And almost all said they felt quite comfortable with technology, and very few actually talked about the need to have additional training. So we also asked about just sort of what was the impact on this 233 respondents on their exposure to COVID. So we can see that virtually, 98% plus really had no exposure to any type of COVID or someone with COVID during their stay. And again, the majority had no signs or symptoms, nor did anyone they know be diagnosed with COVID. And interestingly, we asked about contact with people outside their home. So the majority said that there was a lot less contact, and surprisingly, until actually we read some of the qualitative reports, we were surprised to see that about a quarter of families told us that they actually had a lot more contact with people outside their home. But reading some of our narratives, this was actually for the most part related to their higher exposure to healthcare providers when they were actually in hospital with their baby. So not only for this study, but for others, trying to understand how to best reach families if they're no longer in the NICU. We found that when we asked families how they heard about the survey, that the majority were through Facebook groups, Facebook advertisements, and family and friends. And that, interestingly, families were very open and willing to continue to share their information, with almost 65% saying they would be willing to be reached again for a further research. So when we talk about our parent qualitative narratives, we were amazed at how much families wanted to say and talk. Often in surveys, you use embedded qualitative narratives and you ask families, and many times, or not just families, but survey respondents, and often you get no response. And for us, we just had pages and pages and pages. So we're still analyzing that data. But for today, I just wanted to give you one or two quotes for the 8 questions that we asked as I finish up our talk. And you'll see in the brackets how many respondents actually responded to each of these questions. So I think you can understand the richness of the data that we're currently analyzing. So we asked families to describe their lived experience in the NICU. And one PEI mom said, I often miss meals because I was with my son and meals were taken away by the time I got back to my room. Cafeteria wasn't always open, and I was nursing. I was just very hungry. One New Brunswick mom said, I just felt like an inconvenience. We did not get the experiences that mattered to us in early life. No skin-to-skin contact, no support with feeding. I was in significant pain from my C-section and could not access help moving around the NICU, breastfeeding. I couldn't access medications, and it was just highly traumatic to me. When we asked about if families came up with any ways to stay connected or feel close to their baby or family at home, one Nova Scotia mom said, well, just FaceTime calls or video calls with family. A BC mom said, no, we were told that Zooming with baby was too overstimulating, so we didn't do it. This was hard as we had a 3-year-old at home, and it was difficult to have this huge life transition taking place out of sight of her. And if she could have just seen or visited the baby, it would have been very different. An Ontario mom said FaceTime, but it was really not allowed, so we made quick phone calls when the nurses were not around. And an Alberta mom said, well, FaceTime was the best, but we were asked many times to put her phone away in the NICU. So it made it all very impossible. We asked what was the hardest part for their baby to being in the NICU during COVID-19. And one Nova Scotia dad said, I could not be with my wife after we lost a twin, and his brother was still in the NICU. This has had far-reaching implications for our mental health. It's cruel and unnecessary policy when one looks at the epidemiology. We could have easily co-hosted it as a two-parent family bubble with our surviving baby. We should have been granted an exception. I will never forgive the baby for this. I should never forgive the hospital for this. And an Ontario mom said, the dad and I only saw our son 3 times together through our whole 104-day stay. Admission, his brain surgery, and once when I was part of a family meeting before discharge. I felt like my son wouldn't know who I was because he was handled by so many people. We asked what helped parents cope. Things like free parking, being able to be present, having meals provided, the kindness of the staff. And one Alberta mom said just being able to take breaks to go outside to breathe fresh air without a mask. When we asked about how the family restricted policies affected their baby, one BC mom said, well, I know my milk supply was impacted because I wasn't allowed to be with my son every day. It took us a long time to bond because I had to spend time separated from him. And a Quebec mom said it was so hard to go 4 months in the NICU without ever seeing our son together, my partner and I, and always wearing a mask. Our son got such a shock when he saw us smiling for the first time. It was scary and lonely mostly. When we asked about how the restricted family presence policies related to COVID affected their life at home, a BC mom said, my daughter at home had just turned 1. She was not allowed to come and see her brother and sister in the hospital. We don't have pictures of the 3 of them, and we never will. An Ontario mom said it was hard knowing that every minute I was with my baby, my husband was not, and he was just waiting downstairs in the parking lot. And an Alberta mom said 2 other children didn't get to meet their sibling for 55 days, wondering why mommy was gone so much. It was very difficult. And we asked about what any other concerns that the restrictions had on the parents or their family. And an Ontario mom said, I was only allowed to eat within the designated cafeteria area, making it difficult to find time to eat. It's also difficult to take my medications properly because I needed to eat with them. So it just made my medication schedule be totally thrown off. And a BC mom said, I lost my daughter after a month in the NICU. No one in my family was able to meet her, to know her. That hurts the most. And we asked about, was there anything about the family presence policies that actually made things easier? And an Ontario mom said, hell no. It was like we were experiencing the worst case scenario. And then on top of all that, oh, here are a bunch of resources that we usually offer, but oh wait, since COVID, we can't provide any of them. A Manitoba mom said, not at all. It made an impossible situation even more impossible. So I think I'll leave us there with just a few take-home messages. We know that from our work and others that parental presence restrictions in response to COVID-19 have had significant negative impact on families. We also know that there has been almost no consensus across or within provinces, and that there has been considerable perceived impact on families. We know that there is a huge need to ensure the provision or better access to food, places to eat and drink, as well as access to medications and healthcare. And we know that this is especially relevant for families crossing borders. We know that there needs to be greater focus on breastfeeding success despite restrictions. And we also know that virtual technology, while not to replace and should be considered adjuvant, really has been tremendously underutilized with almost dichotomous use across countries, with some units really using technology to add as an adjective of care, and others actually still removing all ability to families to use this as a means to help with communication and feeling close to family at home. We also know that parents should not be considered visitors. They are essential members of the team, should have access to PPE and vaccines, and more importantly, should have access to their babies. And we need to advocate to ensure that there are at least 2 support people being able to be present. So what is our next steps? We will be closing our survey, as I mentioned, on March 12th. We will be disseminating our findings as soon as possible to help with advocacy, to provide information to various groups who are trying to make differences for NICU families. We are launching a clinician survey because the voices of the clinicians haven't been heard as yet. And we also, I just want to acknowledge again the funding from the COVID Coalition Group in Nova Scotia helped fund this research, and all the parents who took time to respond to the survey so we could hear the parent voice. And also, again, thank you to Fabiana and the Canadian Premature Baby Foundation for inviting me today, and for all you do to support optimal care for infants and families. And thank you very much. I think there's some time for questions.
Yes, Dr. Campbell, thank you so much for sharing your the results of your survey. Very enlightening. But my question to you is, what is the most surprising response that you received from this survey? Was all the results expected, or you're surprised with some of the results?
So we were quite surprised with the access to food, Fabiana, in that to hear that families were hungry, and to feel and to hear that there was, basic needs that were not met. And those are things, I think, from an institutional point of view that could be changed immediately. I think the other thing that, just from our own experience from our health center, where we have seen a significant, is certainly not all restrictions being lifted, but we've seen to support people from one initially. We have seen some relaxation as we've kind of got over that immediate fear. But I think what was shocking to me was that even in families who have just recently completed the survey in the last weeks, there are still hospitals that are not allowing families at all, or limited, and still very much with one support person. And I think that shocked me the most.
Absolutely. And we know from a lot of parents that the situation still remains in a lot of units across Canada. I will share now an interview that I did with Daniela Taylor, who is a mom of Molly, a preterm baby born during the COVID-19 pandemic. She was actually born on June the 4th after being diagnosed with preeclampsia, and which in a few days became the HELP syndrome. Molly was born at 29 weeks, spent a total of 65 days in the NICU in 2 different hospitals in Toronto. And Daniela is going to share with us how the restrictions and ever-changing rules imposed by the hospitals because of the COVID-19 pandemic affected her family and her stay in the NICU. I will play her interview, and Dr. Campbell-Yeo, I will have you back live after to answer some more questions, also to comment on Daniela's experience.
Thanks.
Thank you so much for joining me here today. I'm so grateful that you're taking the time away from Molly. I can see Molly on the background, and I'm very happy to have you here sharing your experience.
Hi, Fabiana. It's very nice to be here. Thank you for having me.
So Daniela, let's start from the beginning. How did you end up in the NICU?
I had a normal pregnancy. Everything was fine. You know, we were all getting like rumors of this new thing coming, and there's a big virus. There was a little bit of stress at work. And I was actually very healthy throughout my pregnancy, and I tried very hard to eat healthy, but I was really craving a burger. So my husband, the lovely man that he is, provided me with said burger. And lo and behold, that night I had started to have really, really severe abdominal pain. And I was like, could it really be the burger? Like, could it really be that? It wasn't that. It was actually severe liver pain due to preeclampsia. So I went to my local emergency room, and the local emergency room said, you are 28 weeks pregnant. We are not able to, we're not equipped to deal with such an early baby. And I was like, hold up. No, there's more cooking, more baking that needs to happen. This is not happening. He's like, no, we're going to transfer you to a better place. They transfer me. I was there for 5 days under very strict observation. And day 6, like the night between day 5 and day 6, those pains came back again. And at 8:20, my doctor said to me, she is coming today. If you want to be her mommy and, you want everything to be okay, she needs to be born today. And I was like, no, put me in a coma. Do whatever you got to do. Like, it's fine. Let her cook. She's like, no, you need to call your husband if you want him to be here. And she needs to be born today. That was at 8:20. And my nugget, who you see over here, was born at 10:25, June 4th last year.
Right. This is 3 months into the pandemic.
This is 3 months into the pandemic. I think it had been declared a pandemic about 2 months prior, maybe 2.5 months prior. It was very new. Everything was kind of crazy and scary. I couldn't have any visitors for those first 5 days. Sorry, parents will understand. Sophie's your best friend.
The giraffe is still around.
So yeah, it was very new. That's how we ended up in the NICU. That's how we ended up, having a baby roughly 3 months early, born at 29 weeks and 1 gestation. She was born.
So let's talk about that time that we were in the hospital, because we know there's so many restrictions in place. It was the beginning of the pandemic, so many unknowns. We didn't know if the virus was, affecting the baby's lungs. So there were so many unknowns back then, and how the spread was happening inside the NICUs, if it could happen. So I know from what we talked about before, there was a lot of limitations of your husband coming and going. So guide us through what you went through the first few days when you were admitted in hospital, pre-delivery, during delivery, and the first days in the NICU.
Deal. So at admittance, they actually admitted me to labor and delivery, thinking that they may not be able to stop her coming, and then that she would come right then and there. And then my husband could be with me that day. When they stabilized me, they said, you're no longer allowed visitors. He can no longer be with you. So for 5 days, we had dinner pretty much like this over a Zoom call while I was in the hospital. And then the day she was born, I think I better introduce her, because otherwise she's just gonna
go ahead.
Okay, come on here, honey. Say hi to Fabiana. Oh, you're a big kid now.
Hi, Molly. Welcome,
Molly.
Live session.
Preemie. Want to say hi? Say hello.
Hi.
There you are. I think she's going to be happier now that she knows.
We are happy to have her.
So the day of the delivery, like I said, at 8:20 in the morning, they said, yeah, call your husband. He better get here as soon as possible. Baby's coming today. And I was very much an enigma. He came in into the hospital. They allowed him in. Then he had to come out because I had an emergency C-section, so he couldn't be there when they prepped me. Apparently I was making very Animal Planet-like noises due to the pain that I was in. I don't remember any of this. I actually remember being very quiet. Apparently I was not very quiet. So he was allowed to be there for the birth. We were very grateful for that. But we were told as soon as I would be discharged, we could only be one parent in the NICU per 24 hours. So from midnight to midnight, only one parent could come. And then right after delivery, everybody said breast milk is so important. Breastfeeding is important, especially for preemies with, risks of neck and all of that. And they, they asked if we're okay with donor milk, all those different things that they ask you in the first few days. A lot of decision making, so many decisions. Are you okay with blood transfusions? Are you okay with, the list was on and on and on. And it was very overwhelming. And there was also no time to really process any of this. We couldn't have any visitors. So, we couldn't have any friends or family come and support us. And that, I know that was very difficult for the both of us. And we basically knew that as soon as I would be discharged, one of us would miss out on seeing Molly. And it was very difficult for me to process because I was her parent, yet I was a visitor. So in my head, I had this discrepancy between what my role should be. There are all these posters in the NICU about be part of the team, kangaroo care, hold your baby, helps with this, helps with that. And then, even to get into the hospital, it was a process that you basically had to jump through all of these different hoops to get to your baby and visit with your baby. I don't like that term, sorry.
Well, we do advocate for a different term because we see parents as essential caregivers in the ICU, not as visitors.
And that's the thing, right? Because if you were to find a synonym for the word parent, you wouldn't say visitor. Maybe an aunt and uncle, a friend is a visitor, but a parent is never a visitor. Parent usually is a caregiver, even at the home, right? Even at home. So that coupled with, us, this is our first baby, us having, being parents for the first time, coupled with the scare that is a pandemic, right? This was last year, this was all very new. None of us knew, what it truly meant. How did it, very little was known about even transmission, even can it pass from mom to baby? Can you still breastfeed if you get it? Can you, all these different things, right?
Absolutely.
So that's kind of how those first few days went. It was very, very difficult. I could barely move. I had actually a fairly complicated recovery. And I was in the hospital 4 days after my actual delivery. And, even day 5, that whole week after being discharged, I could not walk very well. So I would take an Uber or get driven, get a ride to the hospital. And then they would have to kind of leave me at the door. And I'd have to kind of stand in line propped up against the door to wait for a wheelchair. And then I would have to go and get, I remember asking, was like, do you have a lower sanitizer? Because I couldn't quite reach, one of the many sanitizing stations. Then, go through the questionnaire, all of those questions about, have you traveled outside the country? Do you have this symptoms? Have you had this? And some symptoms are, do you have a headache? I'm like, well, I've been on very, very heavy meds for the past 4 days. I probably do have a headache, But yeah, you had to go through all of that. It probably added, I would say, another 10, 15 minutes every morning,
right,
to getting to see Molly.
So, Daniela, how did you manage inside the hospital with a fresh C-section and food? Because we know so many restrictions were put in place. And from the survey that Dr. Marsha Campbell-Yeo just talked about, the parents are hungry.
So I understood, in terms of the mechanisms of infection, it was clear to me that apparently she understood too. It was very clear to me that you couldn't bring foreign things in. Okay, I get it. You can't bring, food. You can't bring a sandwich next to the isolate. I get that concept. However, I struggled with the ability to have a break. And I'll explain a little bit if I may. Mm-hmm. So food time is first I will schedule my own needs based on Molly. Because it was only one parent and because I was the lactating parent, my husband and I decided I would be the one who would be at the NICU every day, at least for the beginning and for quite a few days in a row. And the reason for that was so that I could do more skin to skin, and hopefully my, lactation would, my milk would come in and all of that stuff. The restaurants all around, you couldn't get out of the hospital. First of all, you could not get out of the hospital. If you forgot something in your cart, too bad, so sad, you're not going back in. Once you're in, you're in. The cafeteria in the hospital was mostly closed. I think there was only 2 little food places open, and they had very limited hours. It was like 11 to 1 or like 10 to 2, something like that. And then we were fortunate enough to have one small parent lounge that you could use the fridge in, and you could leave like a little lunchbox, and you would put a name tag on it and leave it there. But otherwise, there was nowhere to go to kind of clear your mind and come back. Mm-hmm. And the reason I struggled particularly with this is because I wanted to be there for some of the procedures that were going on. A lot of the times, the procedures didn't have a schedule specific. We're like, oh, tomorrow morning. It's like, okay, when? Is it 6 a.m.? Is it 10 a.m., right? And then you would want to be there for that. But, you're in the middle between, okay, pump before kangaroo care, do kangaroo care, pump after. Then, you have to do an actual care where you change the diapers and move probes and all of that stuff. And then maybe go to the washroom, have something to eat, come back, go to the washroom again, pump again, hold again. And at least with Molly in the beginning, she was on a 3-hour schedule. So I had basically 6 or 9 hours of not being able to get out at all if I wanted to do any kangaroo care. Because it's not like if my husband was there, he could have held her while I pumped and then we would have just switched. It had to be me doing all of these different things. So in the end, she got less kangaroo care, less skin to skin, and I got, the extra stress and the extra worry of, am I doing enough of this? Am I pumping enough? Should I hold more? She's doing okay on my chest. Should I hold more? But, I feel like my chest is about to explode. I really need to pump right now. Or I'm very, very hungry. Or I haven't gone to the washroom in forever. And those decisions were happening basically every 3 hours. You had to decide, right?
So Daniela, how was that for your husband?
It was terrible for him. Honestly, it was, like I said, we had agreed in the beginning that I'd be at the hospital a little bit more to help with milk and all of that. And we understood that skin to skin would promote milk production. So it was clear to us that, okay, if we want her to have those nutrients and all that, skin to skin should be happening and should be me out of the two. And there were days, there were probably, I would say 5 days in a row every week, or 4 to 5 days in a week where he couldn't come. And it was very difficult for him. We would try to coordinate lunchtime, like his work lunchtime, with a little FaceTime call that we had to obtain permission for. That's the thing that blew my mind, and it really hurt. That one really hurt. We had to obtain permission to FaceTime with our baby, to FaceTime dad to see baby. And I remember distinctly, once the permission was, it was literally like a permission slip. It was a piece of paper that said, so-and-so is allowed to FaceTime so-and-so for X amount of minutes. And we're like, what do you mean X amount of minutes? Leaving that's a conversation for another day. But that permission slip, that had to be posted on the wall. That was on a little cabinet door. So the next time he came, my husband came to be with Molly. I couldn't be there, right? It was the trade-off. So he came to spend time with her, and he saw the permission slip. And the permission slip read something to the extent of, Mom will be FaceTiming due to Dad not coming or not present, or something. I can't remember the exact language, but it was something to that extent. And I remember picking him up and being like, why? I mean, yes, we're upset. Our baby's in the NICU, obvious stress. Mm-hmm. But I was like, besides that, what's happening? There's something else happening. And he said, I would be here if they would let me, right? Mm-hmm. And And I was like, what do you mean? He's like, I saw the permission slip.
Wow.
I saw that. It says that I'm not there. And I was like, you know, and that's when I realized just how hard it hit him, because it was this badge, it was this like, you know, sticker that said, Dad is not coming, Dad is not present. Meanwhile, he's the most supportive, amazing partner and dad, you know, and, you know, according to that little slip, it was Dad is not present, and it really hurt him.
Oh, absolutely. Daniela, how was and I know you were transferred to another hospital after level 2. How was that transition for your family? And how was the you know, the presence in the NICU from both of you at that other hospital?
So things, even throughout our stay at Hospital A and Hospital B, things had changed. It was one of those where it's like, as of next week, you're allowed 2 parents as long as it's not more than 2 hours. It was something like some of the rules seemed very, very arbitrary, and we couldn't quite understand them. And I'll give you an example. Like a lot of the times you would have to change, right, and put masks and gloves and everything to hold baby. Yet some of the staff was wearing like the same things that you saw them coming through the parking lot. A lot of the staff was on the same schedule as we were, right, coming into the hospital to spend time with baby, and you saw them with their clothes from home, wearing them in the NICU, and you're like, well, what's wrong with my clothes? Like, do I have to use a specific detergent? Would then they allow me to do that? Not to mention that from Hospital A and Hospital B, the rules had changed so much that we felt like we now have to spend yet another week trying to get accustomed to what's happening. Like, part of me wished that there was some understanding between these health units and between these hospitals so that things wouldn't fluctuate so much.
Daniela, sorry, Molly just turned around.
Yeah, she's hanging out.
Okay. Oh yes,
she's all good. We have this trick for everybody. Buy a very wide couch, like a wide seat, because now she's doing this. You know, she's turning around.
That is awesome.
She's reaching for her Sophie.
Oh, that's very cute. I'm very happy to see how well she's doing.
She is doing well, and we're very grateful. You know, pandemic or not, the NICU is life-giving, and we are very fortunate to have had the opportunity to have her in the NICU and for her to come out on the other side looking, you know, being strong, and lungs are working well, as you can see, as you can hear.
Let's talk a little bit about how are you doing as a family now, because there is so much separation in the NICU between you and your husband and Molly, and not him being present because of the restrictions. So how are you coping so many months after the marriage?
I'll tell you something, Fabiana. The hardest part, and I may cry for this one. I do not pretty cry, ugly cry. Molly didn't see our full face until we did the care by parent. Until the night before she came home, we had not kissed her or for her to see a smile on our faces. And it didn't dawn on me until I saw pictures of a friend of mine posted on social media celebrating her 1-year-old. And she had posted all these beautiful pictures of her with her newborn baby, holding them for the first few times. And as a matter of fact, she was a NICU mom herself, but she could still hold her baby without a mask, give her baby a kiss, smell her newborn baby. And those were things that we couldn't do. And that was very painful. I will never forget the first time our microwave beeped when we came home with Molly. And both my husband and I were like, you know, because you're so used to every beep and every sound and everything that it almost puts you you're in high alert all the time. Is that right? And, you know, even to this day, she would do certain things like hiccup, right? She would hiccup, and we're looking at her and we're like, we can't believe that only a few months back, hiccups would make you lose your stats. You know, you would lose oxygen, your heart rate would be out of whack. So, you know, I think you can definitely take the parents out of the NICU, but you cannot take the NICU out of the parents. To this day, whoever meets Molly, they don't get to hold her. They wear a mask. The first time grandparents came to see Molly, they were in full on, like, we had purchased a gown, mask, face shield, gloves. And I distinctly remember my mother-in-law, she's the greatest mother-in-law and best grandma ever. She said, I brought a mask, I brought gloves, and we were like, nope, you have to take all of yours off and you have to use ours. And she's like, okay. And we're grateful. One of our social workers had helped us craft an email to our friends and family that were so eager to see her. And we were like, we're grateful, but here's the rules. This is what you have to adhere to if you want to. Not to mention that for the first 2 months, nobody saw her. I'm talking out of the NICU, not in the NICU.
So she went home in a very difficult time in the middle of a pandemic. There were so many still unknowns for us.
Yeah.
But Daniela, I'm so grateful that you're joining me here today. I would like you to just give some words of encouragement to other families who are in the NICU and still facing restrictions. How can you tell those families?
Okay. This may sound like weird or something, but you are that baby's parent for a reason. There's a reason you are mom and dad. And when that baby came, even if it came early, that baby trusts you and knows you, and you will get to know them as well every day, every hour, every minute you spend with them is valuable. It provides a beautiful connection, and you will get there. You will get to this. You will get there, and there will be hard days, but there will also be beautiful days. And it's one of those things where in the moment you can't seem to see past those hard days. But just like I said, she hiccups now, and we all laugh and are very joyful because we know she's strong enough to hiccup, that it's no longer a big life event, to hiccup.
Absolutely. Daniela, for
the
professionals who are here with us today, and we also understand they work in a very difficult circumstances right now. Like there's a lot of added stress being a hospital, working a hospital families right now. What can you tell them?
Thank you for still working on and dealing with parents and babies and pandemic all at once. Please don't use the word protocol to explain anything. Please, please, please. And some things you may have gotten used to as a worker. It is normal for your work day that a baby desats or something happens. That is your normal. However, I can guarantee you from the bottom of my heart that is not the normal for the family that you are working with. And it does seem catastrophic on top of everything to deal with something like that. So it's something that I think, you get used to it as you go through the NICU journey. We were there 2 months, a little over, and you do get used to things, but yeah, it's still not normal.
Absolutely. Daniela, thank you so much for joining us here today. Molly, thank you for your very first appearance on a big TV show for you.
Sure.
We are very excited to have you and see how thriving you are. So Daniela, thank you. Stay healthy and well. And I hope I see you in our social media channels very soon.
Yes, you will. Thank you so much for having me, Fabiana.
Thank you.
Bye.
So here you are, Marsha. I'm going to bring you back. So thank you for staying with us, and thank all of you for watching us and send all this beautiful message to Daniela and Molly. Marsha, any surprises with Daniela's experience?
No, it really was quite clear that the themes that and data that we heard from all of the respondents across Canada really were echoed in a lot of what we heard from her experience. And it just shows us that this is impacting so many families across so many provinces. And I think we need to realize that there's a need for us to try to help provide some of the policymakers some better awareness to understand just what the impact. I think we all can agree nobody's made these decisions because they want to hurt families, because they want to create higher stress. You know, I think they were reactive and they really tried to make the best decisions they could, but that doesn't mean that we can't learn and to really try to make better decisions for sure going forward.
Marsha, there's a question here that came from Shannon. If there are hospital-specific results, what could impact our practices? Would be able to get that data?
So there are, so at this point, we do have somewhat hospital-specific results in that we did ask families to report which hospital they were at. We haven't yet gathered or reported it hospital specific because we also don't want to create, so it's just not the best way to be blaming or to look at it. But I will say that we will report the data, I think also based on the some of the epidemiology, trying to look at those provinces that were hardest hit to try to see if there were any trends and that in the policies that were created. And certainly once we have finished all of our work and have our results collated, we would be more than welcoming to people who wanted to have their specific hospital information. Again, we're not quite there yet, but certainly as we move forward, we will make that available to people who want it to, not necessarily to a broad group, but to each specific hospital for sure.
Absolutely. Marsha, you mentioned the survey is still open. I will share the link one more time here.
Yeah, so there's a sort of on our social media, we've had different things, but just go to MumLink. And again, certainly I feel like there's likely many parents who might be listening who have already completed the survey. But if you haven't, it will be open until next Friday. We'd love to hear your experiences and add that to our work, which we will be publishing for sure. And we will be using this work also in again, some advocacy work, working through with infectious disease groups, policymakers, working collectively with Fabiana to try to meet as many people as we can to try to help make things better for sure.
Absolutely. Dr. Campbell-Yeo, thank you so much for joining us here today. Such a pleasure to hear from you, understand what the situation is across Canada. We know through the stories of the parents, but it was actually nice to see these preliminary results to really see what's happening. And certainly we're going to be advocating with you to have parents in the NICU because we know how this impact can be for a very long time in the family's life. So thank you.
Thank you, Fabiana. And I think the results will be really helpful in when we think about the impact of actual babies who've had COVID or families or the things that we've tried to prevent. If we don't see any of that, regardless of high epidemiology of COVID or low across provinces, then maybe we can think about sort of what is the best approach. Because we do see polar opposites in certain areas as well. So there's lots of take-homes we can take from our Canadian perspective.
Absolutely. So thank you so much.
Thank you for having me here today, Fabiana.
And for all of you, thank you for joining us here today from Facebook, from our YouTube channel, whether you're in a hospital or home. We are very grateful to have you with us for the last 2 hours. And I also want to thank the International and National Family Integrated Care Committees for their work and for the collaboration with CPBF on this talk today. And today's sessions was made possible thanks to our partner, AbbVie. So thank you, AbbVie, for supporting our work here at the Foundation. And the video of today's sessions and all the videos from our live series are available on the CPBF website, which is right here, the CanadianPreemie.org. We are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Please visit our website, consider making a donation. Together, we can create a brighter future to all families. And next Friday, we will continue this important conversation and bring you more evidence on the impact of COVID-19 on family-centered care and the experience coming from UK. We will discuss the transition from the NICU to home during the pandemic and the wonders of breast milk. We will learn about the presence of the virus genome and antibodies on breast milk with the authors of a very recent publication. So more information will be available on our social media very soon. So thank you again, and I will see you next Friday, 1 p.m. Eastern Time. Stay well, everyone.